Thank you, Ranganathan, for your step-by-step approach of hypertension. I am proud to share that he is our PhD alumni. He is a gold medal student in DM cardiology. Right from the student days, his presentation is always very crystal clear. Yes, it's agree with Ranganathan. The basic of measuring blood pressure makes a lot of difference in initiating hypertension drugs. Also, the adherence and concurrent medication. Yeah, it's nice that these three world leaders had a hypertension emergency. The Winston Churchill BP was keep on shooting from 180, 280, 200, 240, 250, 260 like this. How we came to know, how people came to know is his physician has made a note in his personal diary that our leader BP was today this much, that day this much. It was during World War time. So what does it mean? So it indicates, it indirectly says that documentation is very important in our field. That's why even after so many decades, we remember that the world leader, his BP was going on during the Second World period. Finally, he's died of intracranial hemorrhage. Okay, any queries you want to ask from the presentation presenter?
Ranganathan, it was a wonderful talk, especially
thank you.
a note on the non-dippers. So the emphasis on ABPM. One small query: the target you said was around 130-80 or something like that. From the sprint trial, any more reduction around 110-80 or 110-70? Will it be useful? Any comment on that?
As far as the sprint trial, the outcome was good. But as far as the recommendations are concerned, they say below 120/70, in general, it increases the hazard ratio, tolerance goes down, patients can have postural greenness and all those things. So as of now, the recommendation is not to reduce blood pressure below 120/70. But still, we can individualize therapy. Even elderly patients, you can bring it down to 130/80 if provided they tolerate the therapy well.
Thank you.
Thank you.
That was a very crisp presentation. One important thing that you highlighted was the checking for OSA. I think there is one very overlooked factor when we screen patients for hypertension. And we actually find, I have personally seen a lot of patients with OSA who have been undiagnosed before. And they do much better with the home CPAP, and the hypertension control is much better with them. So OSA is one very important factor.
Beautiful presentation, Ranganathan. Here, a lot of physicians are there, and we get a lot of references from lady doctors regarding hypertension, pregnancy-induced hypertension. So we see the pregnancy-induced hypertension is very high nowadays, especially when pregnant ladies, women are slightly on the overweight side. We start on labetalol, and they keep on increasing 50, 100 and all that. When do we start decreasing after delivery? What is the time gap? Generally, they don't come back again to check their BP.
It is very, very important. Even diabetes, they have just to start with, they have gestational diabetes, and then it is very imperative on the treating physician to inform the patient even once they deliver. It is very important they keep checking their blood sugar and blood pressure every 3 months, because many just continue to develop chronic diabetes and it goes untreated for quite some time, and they have all the complications starting. So once they deliver, many of them, they have just pregnancy-induced hypertension and blood pressure starts coming down. But it's very important we screen them every, initially a couple of weeks later, and then a couple of months later, we need to keep screening them. The blood pressure is in the higher range, like if it is more than 140/90, then we need to counsel them to continue medications.
Thank you very much.
Yes, nice presentation, Ranganathan. Actually, I don't remember which guidelines is also that. There is a recent concept that that resistant hypertension, they increase to 4 drugs, which the one drug should include aldactone, because the Conn syndrome, as we think, it's not very rare. It's very hyperaldosteronism is very, very common. So I don't remember whether it's the recent AHA or which guidelines is there. They increase the drugs to 4, which the 4th drug should be an aldactone. I don't remember which guidelines. Please refer to that.
It's definitely not from the European Society, because this many of the slides are from the European guidelines. According to their recommendation, it's 3 drugs. It's ACE or ARB with calcium channel blocker and a diuretic in optimal or well tolerated recommended doses. after excluding white coat effect and after verifying the adherence, still blood pressure is high, we call it resistant hypertension. You add spironolactone only when you diagnose resistant
Potassium
hypertension.
is high, but we have actually there is a recent update.
I'll look into it.
Recent update that we should have four drugs that one should be an aldactone.
Aldactone.
Yeah, excellent talk. You have mentioned AC, ARB as the one of the first line because as an excellent drug for modification. But we have to take it with a word of caution that no renal involvement is there. You said unilateral stenosis, right? So when patients' BPs are very high, so I would suggest be cautious, very like 210, like that. Always rule out the renal problem, anything is there, because it can suddenly worsen, and we have to check it regularly again and again, because it's a wonderful drug, but what we don't know about the patient at all. We are not seeing the first time we are seeing like 220, 120. Be slightly cautious because the renal involvement it will be there underlying somewhere. So that has got to be cautious.
But as such, AC inhibitors, ARBs, there's no particular creatinine value where it is above which it is contraindicated. Any creatinine value, it can be given. But when the creatinine is high and you start them on AC inhibitors, you make sure the patient will come back to you in a week or two so that you recheck creatinine. If the creatinine increases more than 30% from the baseline, then you have to stop the AC inhibitor ARB. Because it is one drug that is going to prevent the progression of CKD. As sir said, any patient presenting with accelerated hypertension, before you put them on AC inhibitors, ARBs, check their creatinine, check potassium, because you might lose. There are important clues when you measure all these parameters.
Yeah, excellent. For pregnancy, second line drug, what would you recommend? Pregnancy, labetalol, because now government guidelines have they put up. We start calcium channel blockers and all that, but some new guidelines have come out, I think so, right? In pregnancy.
Yeah, so the first line drugs are beta blockers, and then as you said, the calcium channel blockers are second line medications.
They don't want amlodipine to be started now. I don't know from how have the persons who check the BP in this thing, they say long acting, suddenly when they are taken for surgery and all that, so suddenly sometimes BP crashes. So shorter acting, actually we don't give shorter acting at all.
Yeah,
it's been such a long time, but now newly they're saying you give shorter acting. Government guidelines.
Yeah.
Methyl dopa can be
yeah,
given.
methyl dopa can be used as well.
Methyl dopa is not available. This way, it's rare to procure.
Thank you, doctor. You presented very well.
Thank you.
And I have three questions. Number one is the lifestyle modification, as you mentioned. What is the role of salt reduction with regards to the BP? And number two is what is the role of dyslipidemia, that is hyperlipidemia in regards to the BP? And what is the role of nifedipine? As he said, the immediate reduction of BP. These are all the three questions. I am Dr. Subramaniam from PSG, Kardivabi.
With regards to lifestyle modifications, sodium has to be decreased. Dietary sodium, sodium chloride, if it is sodium chloride, less than 5 grams per day, 5 grams per day. And some patients ask, can we use rock salt instead of table salt? It is all, you can use rock salt, you can use table salt, but use both, not just, you don't completely switch to rock salt, don't completely switch to table salt. Rock salt has so many other minerals. Table salt has iodine, rock salt is deficient in iodine. So make sure you mix up both, and for some dishes you can use rock salt, for some you can use table salt. That's one thing. What they also say is, based on the recent recommendations, you also have to increase the dietary potassium, which does a world of good to reduce hypertension. Increase dietary fruits, vegetables, which are all rich in potassium. So that is one thing. And then the second question, lipidemia. And any patient with hypertension also has dyslipidemia, then he comes under hypertension with high cardiovascular risk category. So you can try to initiate therapy even at slightly lower levels. You do not wait until 140/90, even 130/80 for some patients, because they come under high cardiovascular risk category. That is one thing. And third, with regards to nifedipine, the recent recommendation, what they say is not to use sublingual nifedipine to acutely lower blood pressure. So these are the three. Thank you, sir.
Thank you, Dr. Ranganathan, for the wonderful talk and discussion. Let me